Good morning. Can you see me and hear me? Can you hear me? Good morning. Can you hear me? There are 83 participants. Testing 1, 2, 3. Okay, can somebody speak so that I can make sure that my speaker is working? I just tested it. Can you hear me?
Yes, sir, we can hear you.
Yes, sir.
Okay. But sadap batan natin mo gagawin. Right. Right. So I have another lecture at 10. So I will finish this within 1 hour. There are 110 participants. We will wait for 1 more minute and then start. Right, we will start now. Can you see the shared screen?
Yes, sir.
Okay. See the shared screen. Okay. So this is the practical on EEG, what is called electroencephalogram. That means it is similar to ECG, that is electrocardiogram, where in ECG or electrocardiogram, we record the electrical activity of the heart using surface electrodes. Here, we do the same thing. We record the electrical activity using surface electrode, but not on the heart, but on the brain. So the electrical activity of the brain is recorded using surface electrodes, that is electroencephalogram. And under the objectives for this practical, I think you need to know the clinical uses of the EEG. That is, mostly it is used to diagnose epilepsy. Epilepsy is, like in layman's terms, fits. If somebody, children and even adults develop fits, sometimes they, involuntarily they shake, involuntary muscle contractions, and then loses consciousness. That is the commonest type of fits, known as grand mal seizures. So these fits are known as seizures. So if it happens, recurrently, repeatedly, without any, most of the time without provocation, you call it epilepsy. But sometimes children develop this type of seizures, especially say about 6 months to 5 year time period. With fever, children develop fits, which are known as febrile convulsions, febrile seizures or febrile convulsions. So if somebody is developing fits, and especially if it is repeated, like if the doctor wants to know what it is, EEG will be ordered and will be recorded, right? So, so in diagnosis of epilepsy, it is used. And secondly, if somebody is having epilepsy, even if you see it, if you are having any doubt which type of epilepsy, because there are different types of epilepsy, you will learn about it in medicine later on, or neurology. You can do an EEG, and by looking at the brain's wave patterns, you can classify, identify the type of epilepsy or type of seizure. And then there are sometimes patients go into coma state, non-responding kind of unconscious state, due to various reasons. Commonest one maybe after a head injury it can happen, or sometimes due to metabolic reasons, hepatic encephalopathy or some other metabolic derangements, patient can go into coma, hypoglycemia, like that. Some of them, if they are troublesome in not responding to treatment, sometimes the clinicians ask to do an EEG, because certain types of coma have characteristic features. You will learn again when you go into clinical years, you will study or learn more about it. But in evaluating a patient with coma, EEG is useful, right? And then another common place for EEG is sleep studies, because there are patients with sleep disorders where EEG may be recorded for a while patient is awake. It can be recorded, and also there are what are called sleep labs, specialized sleep laboratories, where we get down the patient and get him to sleep while EEG is being recorded. And also he is monitored using video camera. So if there's any abnormal EEG pattern, we can see at the same time what is the external outward changes that is recorded on the whether the patient is developing a fit or normal movement, or whether the patient is sleepwalking, that kind of thing, right? So you can study. So those are known as sleep studies. So in sleep studies, EEG is one major part. And then diagnosing the brain death. There are patients who are on ventilators and maintain their life because of the machines connected to him. He is giving artificial respiration or ventilation. But sometimes doctors have to take a difficult decision of disconnecting him if he is not responding, say months and months of ICU care. And then team of doctors will come and clinically evaluate the patient, whether he is actually brain dead or whether he is rescuable, and then they have to take a decision to stop the machines. And sometimes, depending on the country, different countries have different guidelines on how to diagnose the brain death. So depending on the country, most of the time it is a clinical diagnosis of different doctors, anesthetists, ICU doctors, neurologists, sometimes a forensic specialist, and transplant team, because sometimes organs can be transplanted if the patient is brain dead, if the relatives agree, right? And so that type of thing. EEG may play a role, like flatline or some only very deep structures working, no cortical functions, which can be diagnosed. So then if the patient is useless, he cannot survive without the machine. So this EEG may be useful, but it is not mandatory. Sometimes it is purely a clinical diagnosis by looking at the patient and different corneal reflex and other reflexes responses. Diagnosis can be made by the experts, or sometimes it is supported by various investigations. One investigation is EEG. And then another situation where EEG is used to study the visual pathway or the auditory pathway and abnormalities in them, what is known as visual evoked potentials and auditory evoked potentials, VEP or AEP, where you record from the occipital cortex, you get the recording, you keep electrodes on the occipital lobe, and the electrodes also may be connected, and then you ask the patient to look at a light source, and then to give a stimulus through light. Right? So when the light falls on the eye, it will make an image on the retina, and action potential will travel along the optic nerve. And in a normal person, there is a known pattern of stimuli developing along the optical pathway. Optic nerve brings it to, through the optic radiation, it goes to the occipital cortex. So along the way, it generates the predefined known pattern of action potentials. So if that happens normally, we know that patients' connections are normal. But sometimes patients, external ophthalmoscopic examination, all those other things are normal, but the patient says, I cannot see, or there are some internal problems in the cerebral cortex, which can be diagnosed using auditory or the visual evoked potentials. Similarly, you can do the same thing for testing the auditory pathway while recording, to give a sound stimulus and see whether the normal pattern can be seen. So these are some of the clinical uses. There may be other users, but these are things that came to my mind where electroencephalogram can be used clinically, right? You can add if you find anything more, any other clinical uses of electroencephalogram. Right. Let us now look at what this EEG is. So it is something like this. You have the patient, you connect wires on both sides of the head, this side as well as this side. Only one side you see here, only the left side of the patient. These wires are connected, and these other end of the wires are connected to what is called a junction box. They are put into a junction box, connected into a junction box. This junction box is connected to the EEG machine, electroencephalogram machine, which will keep on recording the brain wave patterns. You can see in this one, you can see actually 1, 2, 3, 4. 1, 2, 3, 4, 5, 6, 7, 8. So this is a 8-channel recording. 8-channel recording. You can have 16-channel recording, 32-channel, up to 64-channel recordings are there. So number of inputs will be more when you have more channels. So more localized information can be obtained. And one more thing, in your Canon, if you go to this clinical users, it says something redundant nowadays. That is something that is not used widely nowadays. That is, say if you have some blood accumulated outside the brain, subdural hematoma or some collection of fluid outside the brain, if you record from overlying area, your signals will be dampened or reduced compared to the other side. Other side, high amplitude or normal waves will be seen. This side, smaller waves will be seen because of this fluid in between. So maybe a few decades ago, that was used as a clue to diagnosis to after head injury or something. If you think that there is some bleeding, this will be useful. But nowadays, with wide availability of CT scan and MRI scans, EEG is not used to make that diagnosis most of the time. It is the CT scan or the MRI scan which will show the accumulation of fluid or blood outside the brain. And the neurosurgeon will make that decision to operate or not by looking at the image rather than EEG. So I did not write that here. That's very redundant. Current days, not very useful clinical use, right? So here, coming back to here. So two sides of the brain, left brain and right brain, recordings can be made on a moving paper or can be stored on a hard disk on a computer or the EEG machine itself. Some modern EEG machines have big hard disks which can store it. Or these setups are even now mobile, say even laptop-based EEG machines are there. So regular laptop, you connect it, junction box is connected to here, and the other, or rather the EEG machine is connected. The junction box is connected. The machine is actually the computer. The software is there. It records, and then hard drive keeps the record. Later on, you can analyze. Or older machines, while recording, it gives a printout, like on a zigzag paper. And later it is seen by the neurologist. And these computers or the machines come with software, analytical software also. It analyzes and suspicious areas, they automatically identify and tell this area, look at these areas. So the clinician will have to look at it, but machine will give a clue that there's abnormal electrical activity in this channel, say second channel on at this time, 8:15 a.m. recording is looks abnormal, or 8:17 look at this place, that may be abnormal. So it gives a clue sometimes. Or an experienced person looking at the printout can quickly pick the abnormal areas. Unexperienced person will get really confused what they are looking at, because it is not very clear if you don't know what it is. So here you can see in this channel 1, big abnormality you can see, right? So it's a fit seizure. After here, you can see all the channel sexual activity has increased. Here, particularly, there is some change. So compared to green areas, this area looks more activity, right? So recognizing the patterns is very, takes time. Somebody to learn how to look at the EEG. Not everybody can read them and understand, but we will go through the type of waves and other things. I think must have been done during the lecture, but we will concentrate more on the practical aspect today. So when you record, you keep electrodes on the scalp like this. You don't have to shave the hair. You just set the hair apart and stick it with sticky paste. Electrode is pasted on the identified locations. And say if you put it on the occipital cortex, in the junction box, you have to connect the other end of the wire to the correct place. On the other left, the left side of the occipital cortex goes to the correct place on the junction box. Parietal cortex goes to the correct place in the junction box. Otherwise, your readings will be abnormal or uninterpretable, right? And then you can see it on a screen, as well as get stored or recorded, printed out at the same time, right? And this is a typical EEG machine, where you can see the monitor, you can see the computer, printer, and the EEG processor, probably an additional thing, maybe amplifier through which it is fed to the machine, and the keyboard. And then you can see on a stand the junction box, where wires can be connected from the brain, from the scalp, wires come, and at the end of the wire is inserted to the correct place on this junction box. There are different holes here. I will show a more close-up picture. And in addition, you can see on this horizontal arm at this end, there is a light, powerful light, which is again connected to the machine through wires. And during the recording period, after taking resting recordings, the recordings, you tell the patient, now we will show you a blinking light, very intense blinking light, and keep your eyes open and look at it. And during that period also we will record. So when the light is blinking, sometimes a person's EEG, which is normal during rest, can become abnormal. So to provoke, to induce a fit, you can use it in a susceptible person. Not everybody develops it, but if a susceptible person is there, upon seeing the blinking light, his brain EEG pattern may turn into a type of fit. So much so that I got scared sometimes, like even now auditorium, when there were shows with these blinking lights, LED lights, flashing lights, if there is such a susceptible person in the audience, he can develop a fit actually, right? So flashing light is one reason why fits can develop or provoke, right? So this is a picture of actual EEG recording. You can see different electrodes are attached to the skin using connecting, the electrode gel should be there. The paste, the sticky paste is attached, so the wire will not get disconnected. And they are attached on a pre-selected, pre-known areas. EEG technicians know where to connect them. So on the midline, know how many centimeters away from the midline, this side, and even behind. Sometimes they are connected even on the cheek, forehead, and then these wires are going and getting connected to this junction box. The correct wire, say forehead wire, should be connected to pre-designated place for this. These are color coded most of the time, or the number is written where to connect. And then this junction box is connected to the machine. So the information will be going to the machine, and machine records different channels. So this is with more than 8 channels, no, about 16 channels you can see. And what else you can see in this one? Additional thing than the previous up to now, we did not talk about it. But here you can see what is this on the left upper corner of the screen. What can you see?
Video of the patient, sir?
Yeah. There's a video camera. There's a video camera here. So if there's any, say, when you induce, when you flicker lights, if the patient develops a fit, that will be recorded, and the clinician can evaluate what type of fit it is. Is it only movement of, because most common type that you have seen, or you may see febrile fit, or in a child, what is seen is a kind of generalized fit. Whole body is shaking, goes into tight hypertonic situation, and then tonic state, that is movement, unconscious. So that is called tonic seizures or generalized seizures involving the whole brain and the whole body. But sometimes there are partial seizures. Only one part is affected. Only abnormal movement in the hand sometimes, one hand. Or there's another type known as Jacksonian march. Jacksonian march, where it starts off in the end of the finger maybe, and then it gradually goes upwards. So there are different types of fits. So if you have a video recording, neurologist will immediately diagnose this is what it is. Or sometimes there are what is called absence seizures or petit mal. The previous one is known as the generalized seizures, are known as grand mal, G-R-A-N-D, but pronounced as grand. Or the opposite, or the other type is petit mal, P-E-T-I-T, not grand one, petit, petit mal, where it is known as absence seizures, which is sometimes common among children. Say school teachers may notice the child in the class looking at the teacher, looking at the lesson, participating in the lesson. Suddenly he goes blank. Momentarily he just goes blank and then comes back to the normal situation and goes on working. So that is called absence seizures, where patient does not lose the posture. So the muscle tone is maintained. Patient will not fall down, will not show any other thing. Kemudian just glaring forward, no response for a moment. So sometimes it can happen several times per hour, which can disturb his studies. So petit mal, I will show you EEGs. That's a characteristic type of fit, especially seen in children. Treatments are also different from the others. So when you do medicine or pediatrics, you will learn about them more. But these things can be diagnosed on the while recording, right? So when you record, you give different instructions. I will show you small video pieces as I go on. So this is the junction box, where you can see it is numbered, right? So there must be ground electrode G1, may 22, 23, 24, 25, 27, up to 64 channel EEG recording. And here, is the nose, 2 years, occipital area, Q1 and Q2. We don't know the numbering, I am not familiar, but this is left-sided ones, this is right-sided ones, right? So it is connected in the EEG technicians know exactly how to connect it, and these wires are color coded so that they will not make a mistake. So you can connect it without a mistake, and this send small cup-like thing on the other end of the wire, where you put EEG paste and stick it on the head. And these are electrodes actually. In general terms, these are electrodes. In case of ECG, we don't call them ECG electrodes. We call them ECG leads. Lead 1, 2, 3, or chest leads. So that is the term used for ECG, electrocardiogram. Electroencephalogram, we don't call them electrodes again. We call them montagers. Montage, M-O-N-T-A-G-E, montagers. These electrodes are known as montagers, right? And it is connected to junction box, so it says electrode junction box, and the junction box has a big cable going and connected to the EEG machine recorder, right? Okay, and this is a video. Let me share sounds. Okay, just watch the video.
Oh, Mom, you can sit over there, and Kelly, I need you on this one.
Can you hear? Can you see and hear?
Yes, sir.
Yes, sir.
Fine. Okay.
Big and comfy one is for you. So you're here today so I can record your brain waves, okay? It's really easy to do, doesn't hurt, and basically...
First, Maria measured my head, and when she put the crayon on me, it tickled a little bit. Then she said I could look at the iPad. I didn't realise I get to play games while it was happening. After that, Maria put discs on with a paste, and it was very sticky. It didn't hurt at all. It felt funny when I had the wires on because every time I moved, I realised there was a wire on my head. When I put the netting hat on, I looked really funny.
Wow, cool hat, Kaylee.
Maria asked Mummy to give me some medicine. It was okay, it tasted a little bit like strawberries.
You're doing really well so far.
Okay.
And now I need to keep still and close your eyes for me.
Maria asked me to open and close my eyes. Then she asked me to blow in a colourful
Practice for your
windmill.
birthday.
I blew as hard as I could.
Blow out the candle.
Maria asked me to lie on the bed. She asked me to look at some flashing lights, and it looked a little bit like a disco. I didn't really like it, but it didn't hurt. And it didn't take very long.
Well done.
Then Mummy sat next to me. I got comfortable and went to sleep. When I woke up, I was feeling a little bit sleepy still. Finally, Maria took the wires off my head and cleaned my hair with a cotton ball. I could still feel some sticky stuff in my hair. Maria said,
Right. I mean, it was a little bigger video than this. I clipped it, initial part and the latter part. So what you saw is EEG being recorded on a child. So when you do it on children, you have to be a little smarter than the child. You have to not look threatening and be friendly, give a tap or something to play around, and then get the things pasted and put a thing to secure, not so that wires will not get loosened. And you saw the technician asking the child to blow to a rotating pinwheel, blowing it. So when you blow it, that actually what they do is hyperventilate. So the petit mal, the previous type of seizures, absence seizures I told you, it gets provoked when you hyperventilate. So when during hyperventilation, they appear. At rest, they may not be recorded, but when you hyperventilate, it may appear. So that is how they got them to do it. In an adult, you don't give something to blow. You ask him to breathe fast. Hyperventilate, right? So we'll see there's another video.
Okay. It's all You're tired?
So what you saw is cleaning the forehead. So before attaching the electrodes or montages, you have to clean the area so that good surface contact is there, right?
Okay. It's all You're tired? That'll be great. Now, very carefully, we're gonna go jump on and one sit back.
No, I did not share the sound, so I will do that also.
And try to take a nap.
Yeah, that would be great.
Now, very carefully, we're gonna hop off and go down to the bed.
I'll be always here.
Good job.
Woo.
That's good. Keep it going.
Blow
Can you do 10 more?
10
We
more.
count to 10?
You want him? One,
1,
2,
3,
4, 5, 6, 7, 8, 9, 10.
Good job.
All right. It is all done.
Just the flashing light.
Dash goes, Dash, do you want to go play on the playground?
No.
No?
I gotta go.
Where do you want to go?
I wanna go home.
Pull them out, Mr. Dash. Yeah, I'm going to pull them out. You take this out.
Right. So what you see was a recording of EEG. Yeah, different electrode depending on number of channels. If it is 8 channels, lesser connections. If it is 16, more montages will be placed on the head. And then you secure them in place without loosening, and then record. And initially recording is done at rest. Even at rest, you give instruction. First thing, you ask the patient to close the eyes and get a recording, and then you can ask the patient to open the eyes and continue recording. You may see there's a change in pattern of EEG when the eyes are open and eyes are closed. And then you ask the patient to concentrate on something. You give him a mathematical, question to solve or something, so that he focuses on something and get the recording. And then you ask the patient to hyperventilate. Then you do what is called the strobe test, or the flickering or the flashing light test. And then at the end, you get the patient to rest for a length of time, for about 40 minutes, for him to sleep, if possible, and keep on recording during that period also, because certain seizures or the abnormal patterns occur when they fall asleep or during sleep. So that also is recorded, right? Right, then these things are theory. Most of the things you have seen, or your lecture must have contained. So different waves are there. Gamma waves in problem solving or concentration, and then beta waves, busy and active mind. Alpha rhythm, resting, most of the time with eyes closed, reflective and restful. Theta wave, drowsiness, when you fall asleep, this happens. And delta waves is the stage 3 non-REM sleep. You see low frequency, high amplitude waves known as delta waves, right? So, and as I told you, in this diagram, you can easily see differences, but on a live actual recording, it all look the same. Unless your eyes are very well trained to recognize it, you may not pick it. But sometimes the software itself gives a clue in this area. Abnormal wave patterns are there. It may tell these things. So it's like auto-analyzing software is there. So which may be useful in interpreting the EEG. And some of the characteristics of the sum of the wave patterns. Alpha rhythm, frequency, you can actually, software gives the frequency. So 8 to 13 hertz frequency, alpha rhythm. Beta rhythm, little higher frequency. Theta rhythm, stage 1 non-REM sleep, when you fall asleep, less frequency, 4 to 7. Delta rhythm is very low frequency, stage 3 non-REM sleep, high amplitude, low frequency, 0.5 to 4 hertz. And sleep spindles occur in stage 2 non-REM sleep, and K complexes and sleep spindles. So you can see a spindle-shaped activity known as sleep spindle. These can be spots, spot test in the exam. So sleep spindle you should be able to recognize, and delta wave you should be able to recognize. Low frequency, high amplitude waves, right? And sleep spindle with K complexes is a feature of stage 2 REM sleep. So alpha rhythm, as I told you, is relaxed with eyes closed. 8 to 13 or whatever frequency. Yeah, 8 to 13 frequency. So beta rhythm is when you open your eyes and when you are alert, different rhythm. It's alpha block actually. Beta rhythm means alpha block. Alpha disappears. So this phenomenon is referred to as alpha block, or arousal or alerting response. I think I took this from Ganon. And during sleep studies, you record the EEG, bottom line, and the middle line EMG, electromyogram, that muscle activity, and also EOG, electrooculogram, in order to see the eye movement. So you can say REM sleep, rapid eye movement, lot of eye movements are there, as opposed to non-REM movements. So this is very much active. And So this is awake arousal stage, and different patterns of sleep EEG is there as you go into stage 1, 2, 3. So these sleeps will appear in this stage, right? And delta rhythm is there, low, high frequency, high amplitude, low frequency waves are there. And REM sleep is very much similar to arousal stage, EEG. ඇහැරලා ඉන්නකොට වගේ ඇක්ටිවිටි එකක් තමයි REM sleep එක, right? Right. So in sleep studies, EEG is used, right? And this is important. This one you should be able to recognize. Petit mal fits, that is absent seizures, where patient does not lose the posture or the muscle tone. He is not falling onto the ground or anything, but momentary loss of attention. In children, it is particularly there, and it has a characteristic EEG pattern. When you hyperventilate, you can bring it out while recording. It has a wave and spike. So you have a wave and spike. Wave and spike with a 3 hertz, 3 per second frequency. තප්පරයකට 3ක් වෙන්න, දැන් spike 3ක් වෙනවා, තප්පරයකට waves 3ක් වෙනවා. That is characteristic. And again, common spot test, wave and spike pattern in the petit mal epilepsy. So petit is written as PETIT. This last T is silent. It's not pronounced as petit. It's petit mal. This is also written as grand. It's pronounced as grand mal. Maybe French, right? So here the normal pattern. Suddenly you get a lot of electrical activity, and this is grand mal and affecting most of the channels. Almost all the channels are affected, so it's a generalized one. Even petit mal is generalized, but the wave pattern is characteristic. And then I told you the grand mal or the generalized seizures, commonest one is known as tonic seizures. So you have tonic phase where muscle tone increases, and then clonic. So jerky phase. So jerking phase, EEG pattern may look like this, the bottom last line. Right? All these things are not mandatory to know, but except what I told you, like this one, you must be able to recognize wave and spike pattern, right? Okay. So again, grand mal and petit mal. Petit mal, wave and spike, wave and spike, wave and spike. Right. So that is all actually I wanted to show you. So just remember that you have to instruct the patient to do certain things during EEG recording, to close the eyes and, without thinking about anything, just rest for a minute while we take the recording, and then ask him to open the eyes, get the recording. Again, you may ask him to close the eyes and repeat the recording, and again open, and then get him to concentrate on something, solving an mathematical problem or something. 10 මිලිග්‍රාම් කීයද 10 12 මිලිග්‍රාම් කීයද මොනවා හරි හදාගන්න පුළුවන් ඒවා බැරි වෙනවා මොනවා ප්‍රශ්නයක් දෙකක් අහන්න. And then you get the patient to hyperventilate in order to bring out or induce petit mal if it is there, and then flashing lights, right? So there are practical points also. In Sri Lanka you can do anything, nobody cares, but in the West, if a patient develops a fit, especially for the second time also he develops it, he is not allowed to drive sometimes, right? Until fit-free period. Different countries have different rules. So doctor, if he sees a fit, or if a patient comes to get treatment in America, definitely doctor is bound to report to the driving license agency, the RMV like thing. Yeah, the DMV, Department of Motor Vehicles. Doctor has to report that this patient with this identity card number or social security number came to get treatment for epilepsy, and is please evaluate his driving license permit, whether he is allowed to drive or not, depending on doctor's report, they will decide. So therefore, before recording EEG, you have to warn if you came alone in driving a car, and if you develop a fit because of flickering light during the EEG recording, you may not be able to drive back. Right? So therefore, the patient has to be warned before doing the procedure, and then risk is there. So nothing will happen, but those legal issues are there, right? So, and some of you may, after graduating, may migrate to different countries where you should not fall into trouble with patients and also with the authorities. So therefore, you must know the rules and regulations where you practice, right? And also, if somebody develops fits, you have to give the appropriate advice. You have to take treatment properly without missing. Do not do things that induce fits, like taking alcohol or sleep deprivation, watching TV because it has flickering light. Sometimes too much watching TV may induce it. Sometimes tube lights like migraine and fits with a flickering light, it can do it. And also not to go to dangerous places alone, like rooftops and like open spaces, top stories, or near the open unprotected wells. Those things can be life threatening. So therefore, it's an interesting area, neurology. So you have to be a practical doctor. You must know what to tell and what not to tell, and like the things. Okay, so we will stop there. So I have 5 minutes break before my next lecture. You also can have a break. So I hope you are gathering enough information during these things. I recommend you to top this up, this knowledge what you saw today, with your EEG lecture, and if possible read the canon, which is little confusing, not in a proper organized manner, but it has some information, so you can gather some information required for the exam. So, but petit mal, sleep spindles, as soon as you see it, you should be able to delta waves. You should be able, which is a feature of stage 3 REM sleep. So you must be able to pick them very quickly, right? Okay, so I will stop there. සද්දම්බත් දන්න කවුරු නිදිමතේද ඉන්නවත් දන්නෙත් නැහැ 108ක් ඉන්නවා. This attendance will be marked, okay? So tell the others, I will send the report. I get the Excel sheet of number of attendance and how many minutes you are logged in. All this information is there with your name. So I will give it to the head to mark the attendance, right? So tell the others not to miss these things, right? And I have one more to do, ENG. I will let you know when I will do it. But others will do like perimetry and other things will be done by the other staff members, right? Okay, I'll stop there. If there's any feedback, you can type it in the chat. I will not close. For a few minutes, I will leave it open. If you want, you can type anything.